So SVT for in terms of your cardiac conduction, just as a reminder. So the impulse starts in the SA node. That's the pacemaker of the heart. It goes down AV node to the bundle of His to the Purkinje fibers. There are different types of SVT. It can be that's the most common is that it comes from the top down, but there are some who do kind of an antegrade where they go back up, and we're not going to get into all that because that's a little. All you need to know is about SVT, but know that there are different types of SVT. Okay. During that electrical impulse, the sodium and calcium channels get sent to the cardiomyocytes, and then potassium is inactivated. The only reason I bring that up is because that's important for why we're giving adenosine and what it does. Adenosine is in all the cardiac cells, but for the purposes of what we're going to talk about, that's really why I'm talking about this here. So the first thing you want to do is differentiate. Is it sinus tachycardia or is it SVT? So different causes can cause sinus tachycardia. When we see a baby's heart rate go up to 220, we're not comfortable with that, right? So first thing to do is kind of figure out what is the cause because it's SVT, or is it because the baby's hot, the baby's anemic, are there electrolyte imbalances? So there are a number of things that can cause sinus tachycardia. And we define sinus tachycardia as up to a heart rate of 220. And it's usually gradual. You'll see the baby's heart rate go to 170 for a while, then it'll go to 180, then all of a sudden we're up in 220 and we don't know why. So before we determine that we have SVT, we want to rule out anything that could be just sinus tachycardia. SVT is also usually an abrupt start and an abrupt stop. So there's not a gradual increase. So when we're going to evaluate if it is SVT, first thing we want to do is notify provider in cardiology and then get an EKG. Keep the EKG leads connected because we'll want to use that when we're treating the baby and then right after the baby's treated as well. The other difference between determining if it's sinus tachycardia, there's a noted P wave on the EKG, which we can't always see, especially if a baby has a heart rate of 300. So that's what cardiology is for. So this is the evaluation in terms of what we'll do. Get an ABG, usually a lactate, CBC blood culture, renal panel, glucose, TSH and T4, chest x-ray, 12-lead EKG before, during, and after treatment, and obviously an echo afterwards as well. Okay? So now we've determined, yep, we do have SVT, so what are we going to do? First thing we want to do that we can do are vagal maneuvers. You can use a suction catheter and put it down the baby's throat and see if that breaks it. You can also do rectal stim on the baby and see. Adults will do that. If they're in SVT, they'll try to bear down to get to convert out. And then if that doesn't work, we go to ice to the face. One thing to remember with ice to the face is you do need an order for that. So you want to make sure you've notified a provider that you're going to do that. Fill a bag of ice and put some water in it as well. The one thing you want to make sure you do is you're going to cover the mouth and the nose. And what we tell people when you're doing that is when you do it, hold your breath so that when you're not holding it on there until the baby breaks. You're going to hold it on there until the baby needs to take another breath. And if that doesn't break it, you can do it 2 to 3 times, and then we'll probably go to adenosine, which is our handy tube here. Okay, so adenosine is given IV, and it's always followed by a rapid flush. The biggest problem with adenosine is the dose is usually so tiny that you might have to dilute it. So you can take 0.1 of adenosine with 0.9 mLs of normal saline and mix it so that you're not giving 0.03. You can give 0.3 instead, because otherwise, as you'll see when we're doing the stopcock, it could get stuck in the stopcock because it's very tiny dose. We usually start with 0.02 milligrams per kilo, and then if that doesn't break it, usually we'll double it. You can go all the way up to 0.1 milligrams per kilo. And think about it in terms of if you were going to shock the baby with paddles, that's what this is. So you really want to give it fast and followed by a fast flush, and then hopefully baby breaks. Okay, so who's going to be my...
If you've diluted it, do you still follow it with a fast flush? Okay.
Yes, because you think about where you want it to go. You want it to be in a pretty big vein, but you want it to get to the heart. So you want a big vessel, and you want it as close to the heart as you can. Okay? So who wants to draw up, say, let's do 0.03. For this, I just want to show you like what happens if you're going to end up doing it with the stopcock. You can give 3 to 5 doses. Mm-hmm.
0.03,
Correct.
not 0.3.
Correct.
Can I even that's just a bubble. I'm gonna go a little past it, then push it back. Still just a bubble.
Okay.
There we go.
It's a tiny amount. So you can see why you'd probably want to dilute it, right?
Yeah.
because as I'm gonna have you connect that to your stopcock, to the top of your stopcock. Okay, and then you're gonna connect a flush to the other end. Sorry, I'm so sorry. So that way if you're giving it, so this is connected to the baby, right?
Yes.
Okay, so pretend you're gonna give that to the baby. So you're gonna turn off to your flush, you're gonna push it really fast, and then you're gonna turn it off and flush really fast with your flush. Yes. So you can see your stopcock here? So that could be stuck up in there. So it's probably best to dilute it to 0.3. The way we gave it the other day in the NICU is we just connected it directly to the IV, but there's a delay when you have to disconnect and connect your flush, which you don't want. But if it's that small of a dose, it's going to sit in the tubing anyway. The other thing you can do, and it has been demonstrated, is go ahead and mix it in your flush so that you just give 5 mLs of flush and it's already in there, so you're doing it all at the same time. So different ways to give it.
Could you just do your dose here and then just push, dilute it this way? Or just, you want to dilute it like separately?
Separately, yeah.
So it doesn't get sick, okay, yeah.
Yeah.
But so I could, this is what you're saying, is I could just take this, put it into my flush and then give the flush?
Yes. But don't do a full 10
Right.
mLs of flush, do like
Just do
5.
5,
Yeah.
okay.
Like 5 mLs of flush and you're giving it all together.
Okay.
But best way to do it is dilute it. Like
Is to
take
dilute
0.1
it.
of
Okay.
adenosine, 0.9 of normal saline, and then get to 0.3. That way you can give 0.3 mLs instead of 0.03.
Okay.
Questions?
And you can always refer to the policy. This is the addendum of the policy, the pediatric IV medication policy. So all of your medications on here, and then has all your special considerations and such on there.
And if you can, like for this kid, we gave some sweeties right before, which helped take the edge off a bit. Because if you ask any adult what it's like to get adenosine, they'll tell you it feels like your head's gonna pop off. So it's because you figure you're shocking, so it's gonna be uncomfortable. And this baby cried out every time we gave it. So,
Oh,
so there's.
Lori.